hospice. So this three-part mini-series titled Hospice Care Unraveled, a roadmap to advanced care planning, end-of-life care and grief, and Hospice Care 101 is hosted by the Oregon Nonprofit Hospice Alliance, also known as ONA, in collaboration with its member hospices. ONA brings community-based nonprofit hospices together to provide the best care possible for patients and families facing end of life. As a nonprofit hospices, we are mission-driven and heart-centered in our care, prioritizing people over profits. You can learn more about our work on our website, ona.org. There's a link in the chat. And if you'd like as well, you can sign up for our email list to make sure you hear about any other future offerings or talks or discussions we may have. And there's also a link in the chat as well. So our talk today is about beginning the journey. It's Hospice Care 101. We also have one more talk coming up this month on the 25th with our bereavement specialist on anticipatory grief. You can still sign up for those by going to our homepage or using the link posted in the chat. Before I introduce our presenters today, I'll go through just a few technical details. Lori Kaiser from the Oregon Nonprofit Hospice Alliance will be our tech host. If you have any issues with Zoom, please message her directly using the chat function. If you need closed captioning, you will need to enable it yourself. Today's talk will be covering the frequently asked questions surrounding hospice and clearing up some of the generally misunderstood aspects surrounding it. Our presenters have prepared a few questions on the common FAQs, but we understand you may have some of your own. Once they have covered all of theirs, we will open it up to everyone here. At any time, feel free to write your questions in the chat. We'll compile them at the end and address them. Or when we get to that portion of this segment, you can raise your hand and we'll allow you to unmute and ask your question as well. Please keep in mind that this presentation is being recorded and will be posted online. And then an email will be sent out for everyone who registered to this event. So now I'm very pleased to introduce our speakers today. We have three speakers joining us from the Hospice Care 101 panel. Our first to speak is Julia Luck, who is at LCSW and Care Partners Director of Psychosocial and Spiritual Services. Our second one will be Tracy Villarreal. She is Care Partner CEO, and Tracy has over 3 years experience working in healthcare settings and has been associated with us here at Care Partners for over 20 years. Our last speaker is Dr. Namrate Ragadi, who is an internal medicine physician who has over 20 years experience and is one of Care Partners' medical physicians. I'll start the first question and I'll direct it at Julia. What is hospice, and is it a special kind of care provided to people at end of life?
Thank you, Nathan, and welcome to all who chose to join today. And for those of you who've been dealing with lots of inclement weather and scary situations, I'm sure it's been a tough week for everyone. So just want to start with acknowledging that and also welcoming you. So what is hospice? Hospice really began its origins in the 1970s. Its focus is for people who have an illness that is terminal. So a doctor will make the decision as to whether or not somebody is terminal. The general guideline is that based off of this person's illness, they have 6 months or less to live. And once that determination is made by a physician, the family, this is often presented to the family, and the family makes a decision to opt into hospice. And when they do that, they're opting out of curative treatments, what we think of curative treatments, like inpatient hospital care, ER services. Now, there are some exceptions, and they're opting into comfort care, and they're opting into palliation. So hospice is sometimes thought of as a place. We think hospice, oh, it's a place that you go to like a hospital. It can be, certainly can be. Some hospital systems have it in their hospital. There's people who have hospice units, but in general, hospice meets the person where they are at. So it could be a home, nursing facility, where that person is living at the time. And the goals of care are often comfort, quality of life, and support to the family. So that's what hospice is, and I'll pass it on to the next question, Nathan.
So our next question is hospice only for people with cancer, and I'll pass this one over to Tracy.
Thank you, Nathan. No, hospice is not just for patients with cancer, although we do see a lot of folks with cancer choosing to forego their treatments at the end of life and to receive the comfort and symptom management services that Julia mentioned in her previous discussion. But it can be for many different diseases and serious illnesses. Things like heart disease, dementia, cardiopulmonary diseases like COPD, any kind of liver disease or renal disease, anything that would lead to a belief that the disease is causing a decline and that a person is approaching the end of their life can be appropriate for hospice. And they can benefit from the services that hospice have to offer, things like the symptom management, the frequent visits from the staff, and from input with our hospice medical team.
Wonderful, thank you. Our next question is for Dr. Raggedy. So when should a patient and their caregiver consider hospice?
Welcome, everybody. As Julia alluded, typically we think of hospice when someone would be approaching the end of life, and the eligibility criteria would be someone who has 6 months or less to live. But it's also more a value-based decision where someone feels like their focus is really comfort rather than following curative treatments. So I think that's when we really start to think about hospice, because it's overall a holistic approach. It's different in the sense in medicine, we often are thinking just about treating the patient, but hospice is looking at not only the patient, but also the family. So we are supporting a whole family through this difficult end-of-life process. So that's when, if someone is thinking about all of these, I think that's the time when we can definitely think about hospice as a person or for our family members.
Wonderful, thank you. The next question I have is for Tracy. Does Medicare cover hospice services?
Thank you. The short answer to that is yes. Medicare does cover hospice services, but we find many people have other types of private insurance or Medicare Advantage plans. And those types of insurances also cover hospice benefits. Medicaid covers hospice benefits, and there are some organizations that may take charitable care for hospice patients, although not necessarily all hospices do that. And I think, the important thing is to know that when you are signing up for hospice, that benefit, that insurance benefit, is very all-inclusive. So not only are you getting the services from the providers that are coming to your home or your living situation, but you're also getting all of your medical supplies, your medical equipment, prescriptions that are helping to manage the symptoms of your illness, physician services, and counseling. So you're getting sort of an all-inclusive benefit for all of the care you need without having to go to multiple places or multiple different vendors to receive your services. And so that benefit is all-inclusive.
Thank you. Our next question is for Julia. Does somebody have to be with the patient at all times?
This question really varies, right? So it very much depends on the individual on the time that they enter hospice. So if you have somebody who is coming onto hospice who is a dementia patient, when somebody enters into hospice with a diagnosis of end-stage dementia, generally at that point, they're already receiving 24/7 care. So that's not going to change, really. That's going to continue. So does somebody need to be on with somebody at the time they enter hospice? It depends on the illness and the person's ability. Though a lot of the people that we serve are considered vulnerable peoples, and so they're going to need, some sort of assistance. Everyone at a certain point at the end of their life will need some sort of 24-hour assistance. Generally, that comes from family members, oftentimes, or caregivers, or in a facility. So the answer to the question is that it's very varied. And so some folks do have a fear of dying alone, and they might want somebody with them at that time. And other folks like to just live business as usual, and they want to have as much independence until that independence runs out, right? And then it's a conversation of, how are we going to get some assistance for you? So again, it comes down to what the diagnosis is that they came into the program with. What are their physical needs, emotional needs? Are they considered part of that vulnerable population? And what is the constellation of their resources? So is it a family member doing all the care? Are they in a facility? Do they have a lot of money? Are they living by themselves? So yeah, that's the answer to that. Best of my ability. But as a social worker, I feel like you see a large variety of situations, and it's definitely not always a clear road as to whether or not somebody should have somebody with them all the time. But we'll pass it on to the next question.
Thank you. Our next question is for Dr. Raggedy. So should we wait for a physician to raise the possibility of hospice?
I think it's important that families are aware of their options and explore what they really want to do for themselves or their family members, and what people are thinking for themselves. So we should feel free to bring it up with our primary care provider. We should feel free to bring it up even with our specialists. For example, someone may be seeking care for their advanced heart failure with a cardiologist, or for their advanced pulmonary disease with a pulmonologist. So I think we should be very open to asking questions, to bringing up, sharing our own values with our providers so that they understand where we are and what we may be thinking. Please feel free to discuss it with your family members, with clergy staff, best friends. I think this is more an exploration of what is right for each human being at any moment in time. So you don't have to wait for others to bring it up.
Thank you. The next question I had is for Tracy. What is the difference between hospice and home care?
Both are covered by the Medicare benefit, but if you are looking at what option for home care is right for you, I would say that the differences primarily between home health and hospice is the goal of care. So with hospice, you have the goal of care being comfort, as we mentioned before, support, and management of the symptoms related to the terminal illness. With home health, the goal of their care is really more rehabilitative, and the idea that you are going to recover from a serious illness or perhaps a recent injury. And so there are some other criteria for home health in which you must be homebound. So if you are looking to rehabilitate from an illness or perhaps a fracture of some sort, and you're able to get places on your own, you may not be appropriate for home health. With hospice, it's a little different because, again, we're focused on quality of life, and it is not incumbent that you be homebound in order to receive our services. So we want people with their terminal illness to be able to go to their place of worship, to go to the grocery store, to go to a concert, to enjoy what they can of life without any restrictions on where they're going. And so it's much more negotiated in terms of what that goal is and how they live that out as long as they're able to. Some of the services will look similar, even though there are different goals. Both of those systems have nurses and social workers and therapists that can come to your home and provide different types of care, support, and treatment. But again, the goals are very different in how they live that out.
Thank you. Our next question is for Julia, and you kind of touched on this one a little bit earlier, but I feel it's one of the most common questions you get. So where can hospice care be provided?
Hospice care can be provided where the patient resides. But the caveat here is it depends on the hospice organization's ability to provide care within that specific location. So not all hospices go to certain counties. Some can't provide care to homeless people. There are hospice agencies that do provide that care. In general, we provide care to folks that are in a private residence, nursing facility, adult foster home. It really depends on the needs of the individual. Again, going back to Dr. Raggetty's comment about goals of care and what the patient and family are wanting. And so, you know, I've certainly seen in my career hospice services provided to homeless folks or people in transitional housing, or that are, you know, what I would consider not the most sustainable living situations, but they work. So I guess, again, it just is where that patient resides and the capacity of that individual organization.
Thank you very much. The next question I have is for Dr. Raggetty. Can a patient who shows improvement be returned to regular treatments?
Yes, we have definitely seen that. You know, prognostication is not a perfect science, and we do have people who actually improve on our service. They get excellent care from our staff, from our nurses, our counselors, and we've seen improvement where their prognosis looks like it has improved and they're no longer considered terminal with 6 months or less. And at that point, we refer them back to their primary care providers. So that definitely does happen sometimes. I would also like to allude that at times patients patients have the option. You know, picking hospice does not mean that you are, attached to it forever. If your goals of care change, you may feel like you want to pursue treatment rather than comfort. If newer treatments are available, you could always have that option to go back to that. So I just wanted to make sure that people know that there are many options available even once you come to hospice. Things move differently.
Thank you very much. This question is also for you, Dr. Raggetty. Does a patient have to change their physician when they come on hospice care?
Patients have the ability to keep their attending physicians if they wish for that, and their attending physician would like to continue to be a part of it. A lot of the care that we provide as specialists, including symptom management, pain management, is often managed by the hospice physician. So we always work together, but they do not have to give up their attending physician once they come on hospice.
Thank you very much. And then the next question I have is for Julia. Does the hospice provide any help to the family after the patient passes away?
Yes, we do. So part of the Medicare benefit is that we provide bereavement services for up to 13 months following the passing of a loved one. Sometimes that can be longer depending on the family member need or the friend need. We provide a lot of what bereavement service looks like. Looks different at every organization and different agency, but generally there are support groups included, outreach calls, one-to-one counseling. There's sometimes workshops, definitely literature that a lot of agencies mail out. It depends on the capacity of the agency and who their staff members are. But by Medicare rule, they are checking in with you at least multiple times within that 13-month period. And of course, we do get folks that don't contact us till that 13th month, that 12th month, right? And they go, okay, I'm finally ready for that support that you offered 1 year ago. Things are kind of settled down. And most agencies, I'll at least speak for myself, I would say probably not until month 6 or 8 does a death really hit somebody. You're kind of done with that preliminary stuff that happens when somebody dies, the funeral, the estate. And so now that grief is really coming to the head, and you're starting to feel that. So I find that most folks engage at that halfway of the year, sometimes 4 or 5 months. So again, it depends on the agency and the individual, but by rule it's 13 months. So yeah.
Thank you very much. Next question I have is for Dr. Raggedy again. How do I know if hospice is right for me or for my family member?
I think that's a great question, Nathan. I think part of it is an exploration, being empowered to be able to make your own decisions. Many hospices, including ours, offer an informational visit, so they could gather information. They could talk to the physician to see if you would fit under the terminal, diagnosis, terminal illness, and also talk to your primary care physician to see if you would be eligible and if hospice is right for you. We often have situations where that may not be the case, or a family may decide, no, we want to follow curative treatment right now. And as things change, they reach back to us again and say that our goals of care have now shifted. We are interested in comfort. We would like our family member to be not in pain and to really be comfortable at home. So they reach back to us. So I think it's being empowered with the information that you need, and also discussing it with your providers, with your physicians, because oftentimes they may not be aware where you are in this process. They may be more focused on curative treatment, and that is perfectly fine. But it's possible that your goals may be shifting, and it's okay for you to let your providers know that, so that your providers may not always be aware of what thinking is going on for you as an individual. So please feel free to share it.
Wonderful. Thank you so much. Just so everyone knows, we have 2 more prepared questions that we'll be asking. So if you had one that hasn't been addressed yet, it may be one of the last 2. If not, feel free to write them in the chat, or we'll also do the raising of the hands afterwards, and then we'll just address them in order. But going on to our next question, this is for Tracy. So do you have to leave hospice if you live longer than 6 months?
Great question, Nathan. No, the 6-month prognosis is a prognostication of the best guess of our providers based on the disease process and the symptoms that they're seeing. And so we do see our patients vary in their length of stay, whether that's shorter than 6 months or longer than 6 months. If the symptoms are still needing that palliation and that management of care, someone can stay on services longer than 6 months to receive that care. They may have a slower decline than what was normally expected, but that's part of the process of checking in with our patients and families and making sure that they're getting the care they need at the time they need it. And so if that extends beyond the 6 months, we're staying with them during that entire period to support their needs and to encourage them to live life to the fullest extent they can.
Thank you. And then the last prepared question I have is also for you, Tracy. So I know there are many different, or there's 3 different types of hospices, and kind of what they are. Could you kind of break that down for us and explain the difference between each one?
So I'm thinking about the difference between hospice that's a nonprofit, a hospice that's a for-profit, and then a volunteer-run hospice. And depending on the area in which you live, you may have all 3 of those choices available to you, or you may have just 1 or 2 of those. As Julia alluded to, each hospice serves a certain area in the state of Oregon, your office location, you can serve out 60 miles from your office location. And so for each hospice, they may choose to serve that entire service area, or they may want to focus on a particular city or county, depending on the size of their organization and their staffing and capacity. So for the Oregon Nonprofit Hospice Alliance group that's with us today, as the name would indicate, we are all nonprofit hospices. There is a lot of focus for a nonprofit hospice on the sense of being a part of the local community, of giving back our services, our time, and our money to pour into the community that we're serving, and to be a source of education and empowerment for people to live their best lives. A lot of times we are looking for grants that can help fund some of the programs and services that we would like to provide that are outside of the regular hospice benefit. So we see that as a definite plus to the work we do. Many for-profit organizations may work with, many different offices spread throughout many different states. And so as a larger organization, you may have more bandwidth to serve a larger population or a larger census, but you also may lose some of the personal touches, that you get from being a nonprofit hospice as you're working through corporate rules and structures that may be limiting in your abilities to kind of shift and craft how you would like to operate your business. Volunteer-run hospices are still certified by Medicare, but they are truly not receiving any actual funding. They are all volunteer driven, with the exception of maybe one or two paid position in which they're raising money for.
Wonderful, thank you so much. So that was our prepared questions that we had for everyone. We have a couple of questions in the chat that I'll ask. But at this time, feel free to write any of your questions in the chat. And then you can also use the raise hand function in the little reactions bar at the bottom of the Zoom. So the first question we have, which I'll pose to the group, is the Medicare coverage for hospice under Part A?
Yes. Yes, Medicare coverage is so hospice is under the Medicare Part A benefit. So this is really important because when folks elect hospice, they're electing out of that inpatient hospital benefit. So that's one really important thing that happens. Now, kind of what Dr. Raggedy was saying and what Tracy was saying, folks may change their goals of care. They might decide that they, want to go to the hospital, or they want to be admitted into the hospital, or they might not qualify for hospice anymore because they've gotten better and they graduate off. So when somebody wants to go to the hospital, they revoke. And then when somebody graduates, we say, hey, at this time, you're not meeting the Medicare requirements for your illness. And so you are going back to essentially regular inpatient Medicare Part A. For folks that do not have Medicare, they're going through their private insurance company. Most insurances have the hospice benefit, and it mirrors similarly to Medicare.
Wonderful, thank you. So the next question I have is for Dr. Raggedy. It's kind of a multi-part question. So how do you address the opinion that morphine kills people? Going on hospice means they help you die, quote, sooner. And how do you encourage people to get onto services sooner than a few days or weeks ahead of when they actually need it?
A good question. So Nathan, would you just want to repeat one question at a time?
Of course. So I'll start with the first one. So how do you address the opinion that morphine kills people?
there are many different opinions, but the truth of the matter is that medically, we are aware that morphine is available for comfort and alleviates the pain of the patient, but it's not directly responsible for hastening death. This is part of the medical literature. So we as a hospice believe that we are here to take care of the patient and really make them comfortable in those really difficult moments at the end of life. We use medications in a very specific way, which is tailored to the patient. So it is not a one formula fits all. We are in very close communication with our nurses who are actually going and visiting the patients at the end of life, seeing them very frequently, and just giving them medications that is absolutely needed, and also collaborating with the family on this. So we do this tailored to each patient individually. Nathan, what would the second question be, please?
So the second one was going on hospice means they help you die sooner. Kind of how do you address that opinion and that feeling as well?
Disease will follow its natural progress. So what we're looking at is people who come on hospice have a natural progression of their disease, of their terminal illness. And we are not interfering with that. That is following its natural course. We are here just to support people physically, emotionally, and spiritually during that time. And that is what's unique about hospice, is we have an interdisciplinary team. We have Julia, our social worker, and her team of chaplains. We're here to support the patient as they navigate this, the family members. So we are more a supportive team as the disease is following its natural process.
Thank you. And then the last portion of that is how do you encourage people to get on services sooner than just a few days or weeks ahead of time?
Our goal here, and as all of you are present, is education. We are not here to encourage or force anyone to come on hospice. We are here to empower you. You are the decision makers of your life and your choices. And we are here to provide you with the information that you need to make whatever decisions are right for you. I just want to share with the group that I had a close family member last year who was diagnosed with a terminal illness. So it was a very personal experience. And the initial decision was, do we go on hospice immediately? And we elected to do some palliative chemotherapy. And when we got some couple of months of good quality of life, and when things declined, that's when we chose to move towards hospice and palliative care. So it's a very individualized decision for each human being and for each family member supporting them. And that's what we want to be here with you in that journey, if you would like us to be there. Because I think a lot of numbers by the National Association, which follows hospice, do show that about 50% of the people who come on hospice are only on a service for about 18 days. What that means is we're not able to give you the full benefit of what we can provide, what our whole group can provide you, our interdisciplinary team. And what we want to do is support you through that.
Thank you very much. So the next question, which is which type of hospice is Lumina? So all three affiliates of ONA, the Oregon Nonprofit Hospice Alliance, are all individualized nonprofit hospices. So each one is kind of managed and run by themselves, but we do share resources through the ONA and and best practices and stuff like that, just so we can put as many dollars back into providing care and putting our patients first, and kind of using the benefits of some of those large conglomerates and those big companies, those big for-profit companies that may have a lot more dollars and a lot more resources than we do. We can kind of pool our resources together and make ourselves larger, but still keep our independence, still keep the fact that all of us are around 40 years old. We all service our community. We were kind of raised in our community and kind of have grown with it. So thank you for asking that. And then the next one will be directed towards Julia. So does ONA hospices support people who choose death with dignity?
You know, I'm sorry, I'm newer to the organization, so I'm going to speak specifically to care partners, if that's okay, Nathan, and then other folks can chime in here. Yes, we do support folks that choose death with dignity in the fact that we do have several patients who do choose that line and they make that decision. Our nurses, of course, in order to use the medication, the patient has to, you know, of course, be able to mix it themselves and take it and go through some kind of rigorous screening prior to. And so, you know, we're there to walk along the patient's journey. And if death with dignity is part of that journey, then that's what we're going to help the patient. You know, we're not going to, of course, give the medication, but we will be walking with them. And a lot of times, you know, people have the medication and they don't take it for a while, right? They kind of want to choose that date and they spend a lot of time thinking about it. And it can be basically we're here to support the choice that people make. And if that's the choice that people make, we're going to continue to manage their symptoms and support them until they do choose to do it. And then their family as well, because you know, when somebody does choose death with dignity, it's a little bit of a different type of grief for some family members. And so, yes, that's the answer to that question. Anybody else want to chime in, or Tracy can chime in here?
I did want to just add one element that sometimes I think families may not think about, is that even if your hospice is supporting you through the decision to enact or choose death with dignity, certain community locations, facilities are not supporters of death with dignity. So if your loved one is living in a foster home or a nursing home, or perhaps even an assisted living, those communities may not be on board with having those services delivered in their communities. So I would encourage anyone who is, you know, thinking about this as one of their options at the end of life to also keep that in context and be having that communication and correspondence with the community where you live or where your loved one lives, because I have personally seen experiences within our own hospice where patients had to relocate from their place of residence to a different location in order to enact that process. And so I just want people to be kind of mindful of that. Again, our role as a hospice is to support people's decisions. We're not hastening or postponing death. We're letting death take its natural course, as Dr. Raggedy said. And so therefore, you know, if this is the course that someone's taking, we're not playing a hands-on role in that. We're playing a supportive role.
Yes, and thank you, Tracy, for mentioning. I also want to add, it also depends on the individual organization. So Catholic organizations, they can't support this. You know, their healthcare directives specifically delineate that they're not supposed to be supporting this. So if somebody's goal is death with dignity, then of course, you know, they're not going to be going to a Catholic health organization's hospice because their staff can't support that. So, you know, that's you know, also with other religions as well. So there is that component. Is I wanted to add, there are a lot of there's a large Catholic health system, as all of us know, in Oregon. But I think that just also wanted to add that piece too. Yeah.
Wonderful,
you.
thank you. One thing I would like to add as well is, so we've done a good number of these lecture series throughout the years. So on our YouTube channel, I'll post the link. We went actually in more depth about death with dignity from one of the representatives from the state. So there's a link there, and then you also have other videos and other talks that we've done throughout the last year. And then this one will also be uploaded on there as well. But continuing on with the questions, on this one for Tracy, what is the role of a volunteer hospice worker?
So by Medicare guidelines, every hospice has to have a core group of volunteers that are working in their organization and to support the care of the patient and family. We have many volunteers that do many different things within the body of our organization. We have some volunteers who do direct service with patients, and so they may come in to a patient's home to provide respite to the family members, so that the family members can get a break and go to the store or go out to lunch with a friend and not have to worry about their loved one being home alone. We also have volunteers that come into the office. We have some volunteers who answer phones, who do some, office work and photocopying and spreadsheet and data analysis. So we try to look at each individual that comes to the hospice that wants to volunteer and look at their unique set of abilities and talents and how we might best be able to utilize those within the organization. We also do a lot of community events, and sometimes our volunteers are really helpful in helping to set up and organize and get things moving from one place to another, or to man a booth out in the community and speak to the work that we do. So there's usually always a place for someone here. We never turn away volunteers, and I think probably Lumina and Klamath would agree with me there.
Wonderful. And the next question is for the group, and kind of goes back to the death with dignity. Is there any reason the facility has to know you want death with dignity? Even does the hospice need to know?
And Dr. Raggedy and Tracy can definitely step in on this one. Absolutely. The answer is yes. So death with dignity, the medications that are prescribed are considered a controlled substance. And so, anytime you have that in a nursing facility, it's like an order, right? So they're going to need to know what comes in and out of their facility medication wise. And yes, the hospice needs to be aware of when you are going to do it. We're oftentimes not always there. But yes, it's considered a controlled substance. So yeah, both facility and hospice would need to be aware and involved understanding. Yeah.
I think too, just to sort of tag on to what Julia's already said, there are many people, when they choose to take death with dignity, despite the fact that that's their wishes, that may be feeling anxious, that may be feeling worried, about either how the process is going to go, or about worrying about their loved ones who may be there with them during that moment, and making sure that they have the right support. So really, again, to let the hospice know, even if it's just to say, we don't want you here during this moment. This is a private family moment, but we want you to know this is happening, so that if something either goes wrong, or if you could just please follow up with our family member after the process is done and make sure that we have everything we need. It just makes sense that we want to be there, really from the beginning of the process through grief and bereavement. And as Julia said, that 13-month window that we are supporting the families beyond the patient's death really, starts from the day we enter the lives of those folks in terms of building that relationship and that support. So no, we don't have to be there and be present during the process, but I think ethically it's important for us to know, and for the facility to know, that it's happening, so that we don't, insert ourselves into a place that is uncomfortable. And again, if someone's worried about, getting kicked out of a facility, or getting, having to move, and that's not something they want to do, and they're trying to keep that sort of under wraps, our hospice team is, knowledgeable about other choices, and helping to, help people understand, what their options are. So even though we may not be the people that are there with you at the very end, if that's not something you choose, we can get you the education and the people that can help you and be there right then. if that's what you're needing.
Wonderful, thank you. And then to kind of add on to that, and I think this would probably be for Julia, could you explain the different types of grief a family has after going with death with legal duty?
Yeah. So, you know, the way that somebody dies often impacts the way that we grieve, right? So if it's a sudden loss, that loss feels very sudden and shocking. If it's a loss related to a terminal illness, that, well, anyways, any loss feels differently, right? So the way that we pass often influences the way that we grieve. Now, it's not a perfect science. When somebody chooses death with dignity, you might have had, for example, a daughter who was being supportive of her mom or father at the time, and was trying to be the best daughter that she could be, and was there and present and was supportive of the decision, but maybe ethically her inside wasn't feeling okay with that decision, but she never really fully expressed that. So sometimes there's an ethical conflict, because although family was present in there, they might not have agreed with that decision, but continued because that patient had capacity to support that person. So sometimes there's that little bit of ethical discord. Some of the questions that they get is, did I do enough? Did I try hard enough to make this person comfortable? Was I a good caregiver? And I find that, I think a lot of people support their loved one in this process. And then there's family members who just, could not wrap their brain around the decision that this person made. And so that comes up in the grief process, right? Because we're questioning those things. Those are natural things to question. And so it's kind of unique in that way. And sometimes people feel also too, like, almost disempowered by it. I've heard sometimes, like, mom got to make that big decision and I had no part of that process. And that was kind of, so I've heard that word before, like she felt really empowered and I felt really disempowered. And so it's a very unique situation. It's, I think it really depends on the individual. Also the relationship with that individual at that time of death. What was your relationship with your mother or your brother or your father? And do you have that guilt or that shame or that questioning because of that? So I don't know if that's a helpful answer. I guess it just really depends on the individual.
Wonderful. Could one of you speak about terminal anxiety?
We do often see patients at the very end of life who, may be struggling with what we call as terminal delirium. It could be confusion, anxiety, and that's why we're really there to support them with, and the families, with medications as needed so that we can keep them comfortable, and also help the family as the family is trying to keep their family member comfortable. So we are there to evaluate it, to see what's needed to be done in the moment. We guide the family, and we are present. We are available through phone calls. We do frequent check-ins. So really, it's a very hands-on approach to really helping the family navigate that and the patient.
Thank you. So that looks like the questions we have for now. If anyone would like to raise their hand, if we have any questions left over. Oh, I have one more. Is terminal anxiety connected to spiritual doubt?
I can, Dr. Raggedy, you want to piggyback with me? Okay, so the terminal anxiety that Dr. Raggedy, I think, was speaking about is more medical in origin. It's related to that disease progression and kind of that person's point in life. And so sometimes that can be related to the actual disease. Is there a spiritual component to it? Sometimes, yes, absolutely. There's this, it can feel like the person is maybe, sometimes they might be hallucinating, and be very anxious about those hallucinations and seeing things that they don't want to see. It also depends on past traumas. Terminal anxiety is a very specific medical term. But medical or just regular anxiety, doubts, existential crisis, that's a separate thing that we deal with patients. So somebody can have terminal anxiety that's medical in origin, And then somebody can have anxiety related or spiritual existential questions that are related to their illness and facing the end of life. And so what we see oftentimes is when somebody is transitioning or heading towards their life, they'll have hallucinations or visualizations that are spiritual in nature. And sometimes those are very pleasant ones, and they don't bother the patient, and they see these visions and it doesn't seem to bother them. And sometimes they're hostile in nature and and they do cause anxiety to the patient. And so again, it's about the individual. So they're kind of two separate things, but also related, if that makes sense. So I think it depends on what the manifestation of that terminal anxiety is like. And then, if those hallucinations and those voices that they're hearing are causing severe stress, then of course we're going to treat that problem. I've also had people who've had lovely visions at the end of life, and they've seen loved ones that passed long ago, and that's very comforting for them. Or they've that they are, kind of enjoying seeing these little girls in the room. There's also that when I going back to the spiritual doubt and the existential questions, I think it's very natural for people to, at some point in their illness, feel or question their life. And sometimes spirituality comes into that. But I also see the other side of things where spirituality becomes a big thing that they lean on, right? That they lean on for that source of strength. And so, again, it really depends on the person. And Dr. Raggedy, you can chime in, or Tracy, you can chime in.
I was just going to say that, I think as a whole, right, one of the reasons that hospice can be so effective at the end of life is because of the multidisciplinary approach, right? So anxiety might be something that is tended to from an emotional mental health perspective. Anxiety might be something that's driven by a medical physical diagnosis. Anxiety might be something that's existential and spiritual in nature. Hospice has all of those professional disciplines that are blended into providing care and support. So each professional is going to treat and help with those symptoms from their own discipline and their own perspective. And so we hope that with the team's input and the team collaboration, that we're able to get at any of that anxiety as a whole by approaching it from many different angles.
Julia and Tracy, you've done an excellent job of really going over it. So I think that's a great summary. So it's really for us to I think all components play into it. And as Tracy said, the team evaluates where we step in to help. If your anxiety is from shortness of breath, it's from dyspnea, it's because you can't breathe, then we will use medical medications to help with that. And, so each component is looked at and supported. And that's really the beauty of hospice, is like we have a whole set of group members here to support you in that moment.
Wonderful. Thank you all. I'll give just a few more seconds for maybe one last question. We have a few more minutes. If not, I want to thank you all for coming, for joining us. Like I said, we still have one more event that it will be next Thursday at the same time, 1 p.m. This is specifically on the grief. And what I also linked earlier was our YouTube channel, where you can find this, as well as any other past lecture series we've had. I want to thank you all again, thank our panel here, and thank everyone for attended. It means a lot to us, and I hope you have a great rest of the week, and thank you for taking the time to spend this hour with us.
Yes, thank you very much for everybody that attended. We appreciate you.